Welcome to Straight Outta Health IT. Getting into health tech is rough, but here's an unfiltered dialogue of healthcare leaders and influencers covering a wide variety of issues affecting healthcare and the health tech industry. And now your host, Christopher Cunny.
Hello, everyone. This is Christopher Cunny, and welcome back to another episode of Straight Outta Health IT. Today, I'm excited to talk to a subject matter expert on a topic that I think a lot of us are dealing with as we get older, as our parents get older, or grandparents, etc. This is something that from time to time will rear its ugly head in our conversations about our overall health. And so the topic that we'll be covering is, the title of this podcast is what I call Bone Deep, Unveiling the Myths and Realities of Osteoporosis. So let me jump into this a little bit more for those who may not be familiar with this disease. Osteoporosis is a bone disease characterized by low bone mass and deterioration of bone tissue, leading to an increased risk for fractures. While it's often associated with women, it is essential to recognize that men also are susceptible to osteoporosis. In fact, 1 out of every 4 men over the age of 50 will experience a fracture due to osteoporosis. This misconception that osteoporosis only affects women has led to an underdiagnosis and undertreatment of men. So joining me today is an individual who is a subject matter expert on this topic, and we'll delve into this in greater detail. Let's welcome Mr. David Lee, the founder and chief collaboration officer of Health Collaboration Partners, which helps healthcare startups, nonprofits, and pharma companies launch their products and technologies into the market. Who is David? Well, David is a leading expert on osteoporosis and bone health. Given his roles running the National Bone Health Alliance, a public-private partnership on bone health that included more than 55 associations, the global marketing program lead for Amgen Bone Health Portfolio, and now supporting a number of nonprofits and industry osteoporosis leaders throughout his consulting work since the mid-2021. A particular focus has been an implementation of post-fracture care coordination programs that ensure patients receive appropriate screening, diagnosis, and treatment after fractures. David has also had 30 years of experience and leadership in the nonprofit and biopharma sectors, including roles at Amgen, National Osteoporosis Foundation, the Foundation for the National Institute of Health, the Last Acts Partnership, Director of Policy Program, and the American Gastroenterological Association.
Maybe do one that you just say the American Gastro Association.
We'll go with that. I'll let you go with that. So thank you, David, for being on the show. I'm so excited to have you here today. Before we get started, I know the question I always ask my guests is, that was your very impressive resume that I read, but it doesn't always talk about your personal journey, right? And what led you to do what you're doing today. And so I'd like to take a few minutes to maybe share that.
Sure. Yeah. So as you said, I've been in healthcare for over 30 years. I think if I do the math, I've been in the osteoporosis space for about 13. And I guess for me now, it's not only professional, but personal. So the personal side is my mother has actually also suffered from osteoporosis and is the victim of the care gap that we're going to talk about in a minute, in that right now there's only about 20 to 30% of women after they have a fracture get not only that risk casted, that hip fracture repair, whatever they might need, but only about 20 to 30% are actually getting diagnosed. And then if they have osteoporosis, being put on an appropriate therapy. So in my mom's case, just to put a point on this care gap, she had 2 fractures, fall from standing height, which is, we talk about in the osteoporosis field, is the definition of a potential osteoporotic fracture or a fracture caused by osteoporosis. She had these 2 fractures, both elbows, which also made her have to stay in a rehab hospital for about 6 weeks at the very beginning of COVID, before we had any therapeutics or vaccines. So obviously a very scary time to be masked 24/7 in an institution. Like, this was March 2020, saw an endocrinologist. So the way that we diagnose, one of the big parts that diagnoses osteoporosis is something called a DEXA test, which is a bone density test. And the clinical definition of whether you're low bone mass or osteopenic versus full-blown osteoporosis is a T-score, which is the measurement score of negative 2.5. She had a negative 2.4, but any bone doctor would have known that having something very close to full-blown osteoporosis plus 2 fractures should equal a pretty aggressive biologic bone builder. Because she didn't have that magic number, he put her on a bisphosphonate, which is among the kind of older therapies that called Fosamax. She had GI issues, so went off that medication. The doctor didn't replace it. So she unfortunately then, about 3 years last fall in October, broke her toe, and then within 24 hours broke the top of her shoulder because she was fell in the bathroom.
Wow.
So she now had 4 osteoporotic fractures. She had a second 5 or 6 week stay because, of course, it was right foot, left shoulder.
Right.
And now she's had 2 6-week stays. They fixed 4 fractures. Luckily, because of my previous roles in working with a lot of the leading key opinion leaders, I was able to find a bone doctor in her location, which is Charlotte, North Carolina, that was able to diagnose her, did put her on one of the bone builders, and is now about 6 months into that journey. In about 6 months, we'll get to see the repeat DEXA to see how much her bone density has improved. But it's just a real example of the care gap and the fact that you can't just fix the fracture, but that if you don't fix the underlying disease, you're going to continue to fracture over and over. And I can tell you, I've met patients that have literally had 6, 7, 8 fractures over a 10 or 15 year period that no one, healthcare professional or family member,
correlated at all.
Not. And I think what's really frustrating about this disease is that it's a silent disease and that you don't feel your bones are weak before you break something.
Sure.
And for many patients, they may be thinking about osteoporosis while they've got the cast on their arm, their wrist, whatever, but then it becomes out of sight, out of mind. And certainly compared to, say, arthritis, diabetes, other chronic diseases that if you don't manage them, it affects your day-to-day. I think it makes it a little bit harder for patients to prioritize. But in terms of the statistics, and even in 2010, about 54 of the 99 million people age 50 plus, and we talk about the cohort of 50 plus is where we would suspect osteoporosis. Obviously, if you fall when you're 25 or have a high-speed auto accident, probably don't have osteoporosis, but we talk about 50 plus population as the folks that are certainly at risk. About half of those folks have either osteoporosis or osteopenia, low bone mass. But then as you look into the future, because of course, the aging of the population, it's going to continue to accelerate. In 2005, we had about 2 million fractures caused by osteoporosis. Currently, it's estimated we'll probably have 3 million by 2025. So in just a 20-year span. And that fracture liaison service, that care coordination model that you mentioned, is really the way to most efficiently find these patients once they have a fracture, making sure they don't just get the surgery or casting that they need, but that they have that diagnosis. Because as we know that in general, all of these drugs lead to about 50% fracture reduction risk. And then even in the interim periods or in the initial period, we call imminent risk. So there's about an 86% chance that once you've had a fracture, you're going to have another one within a year unless you have that diagnosis and go on therapy if needed.
First of all, I want to stop and say my heart goes out to your mom.
Thank you.
That she is wishing her speedy recovery. And you said some pretty profound things that really had me thinking as well, too. I'm over 50 and I try to go on an annual basis to get an annual checkup and the normal things for a male, prostate exam, blah, blah, blah. But no one's ever asked to check my bone density.
Right.
That's never come up in a conversation with my primary care physician. And I guess now I need to bring that up to them. Why do you think this is not something, clearly, to your point, it's a progressive disease. It's something that affects a large percentage of our population as we get older. Why is this not a part of the normal checkup process, maintenance process that a primary care physician or specialist would be?
Yeah, I think it's a couple things. So I would say on the primary care side, if you've got 20 minutes to talk to your doctor about 3 diseases, unless you have a cast on your arm, it's probably not going to be osteoporosis. And then I think as well as I've learned, one of the interesting things about bone health, which I think is a challenge, is that there isn't one specialty that are the bone experts. Sure. So it's a combination of endocrinologists, rheumatologists, orthopedic surgeons, some PCPs, some OB-GYNs. So it isn't like you go to a specific doctor with this disease. So I think that's also what leads to the gap and then back to the primary care, because there are a lot of therapies available and that there are also multiple specialty societies that have their own guidelines and they're 80 to 90% aligned. But I've talked to PCPs and sometimes they go, I don't know if I follow ACP, American College of Rheumatology, the Bone Health and Osteoporosis Foundation. So sometimes they just decide to do nothing or they try to refer out. And the challenge right now from a specialty perspective is I know the average wait time to see an endo or a rheum, which tend to be the osteoporosis diagnosis expert, is 6 to 12 months. So if you're thinking that you've just had a fracture, and per that stat that I said that there's an 86% chance of getting another one within a year, if you can't even see a doctor for 6 to 12 months, and then on top of it, if they prescribe a medication, it's not going to work on day one. It's going to take a while to build that effectiveness and start to build up your bone density. You've got maybe a year and a half or 2 years that you're, as a patient, in the danger zone. And I guess the other thing I would mention to your question is that most of the guidelines say that you should have a kind of your baseline DEXA at age 65, and even some of them say in men it's age 70. But obviously, if you have a fracture,
by that, it has progressed.
Exactly. And as we talk about in bone health and osteoporosis is a lifetime disease. So you build your bone bank through about age 30. So all of the things that you do as a kid, adolescent, young adult in terms of diet, exercise, especially calcium and vitamin D, which of course are the two kind of minerals that are most important to build and maintain and turn over bone. If you don't do that, you're going to start withdrawing from that bank at age 30. And then the reason why this tends to be about a 75% female, 25% a male disease is because women lose up to 20% of their bone density as they go through menopause. So even if they were in good shape at age 42, by the time they're fully through menopause, they might be osteoporotic. And then there's certainly a lot of other drugs and things like glucocorticoids. If you've gone through chemotherapy and you look at all the drug ads on TV, and I feel like half of them have bone loss as one of the side effects. So certainly depending on other diseases you might have, that might also lead to osteoporosis, even if you're at a younger age. I can tell you, I'm now in my late 50s, and the cohort of especially women that I have referred to doctors that I've worked with, it's probably a good dozen people that are still on the young end. And I think there's still this impression, as you said, that 70s and 80-year-olds that are having hip fractures, but really most patients have had a vertebral fracture, something earlier in their life that should have been a trigger to get diagnosed and treated. And as you said, if you're kicking the can down the road or you don't know that you have osteoporosis and then you have a major event
or a fracture or something,
the trouble starts. And just as an example, the mortality rate 1 year after a hip fracture is about 25%. 1 in 4 in the hip fracture are no longer with us within a year. And I remember joining the bone field in 2013, and I literally thought that could not be a statistic that was right, that it was missing a decimal point because there would be no way. 1 in 4 people dying from this disease. And then on top of it, of course, for people that have a hip fracture, they will have a pretty decently long stay in rehab. And many of them, unfortunately, about half of them will end up going from independent living to a nursing home or some kind of institutional living because their activities of daily living don't come back. And many times even someone that passes away from the hip fracture that was the sentinel event, it might be sepsis,
needs other things
on the death certificate, and not the doctor may not even
the root cause.
The osteoporosis was really the house of cards that really challenged that patient.
You mentioned some of the risk factors associated with it, menopause being one of them. I'm just curious, what are some of the other risk factors, especially for men, since it's something that we don't really think about?
Yeah, I would say the big ones, certainly smoking, excessive alcohol use, folks that have gone on glucocorticoids, that really can really deteriorate your bone health. The interesting thing about men, too, even though it's 25% of the fractures, the mortality rate for the hip fractures in that population is like 37%, which is higher than that 25% that I quote. And then also there are some of the drugs that aren't even approved in men. So there's also that challenge that they can be used what's considered quote unquote off label. And I've talked to men that have been in their late 60s and they have not even gotten approval to get a DEXA test. Though there definitely are, because to your point, it is perceived as a female disease. So I think those are some of the other challenges that we're faced. in this field, and why at times it's a very frustrating place to be, because we've been trying to drive this awareness. But I think one thing that's coming to the fore, which I think is really helping accelerate how we do this, is a lot of the AI and machine learning companies that are bringing to market various ways to measure bone mineral density with an X-ray, CT scan. Because the other thing to say is that on the DEXA side, there is a disparity in the reimbursement in the office setting versus the hospital setting. So that's led to many less DEXA machines in the office. So instead of before being able to have a visit with your endocrinologist, walk down the hall, get your DEXA, come back and get that DEXA results, you're now having to go to a hospital. And if you're a rural community, you might be having a couple hours. And then because of many less DEXAs, I've talked to folks that have said, hey, I can't even get someone a DEXA scan for 6 months. And you've got this long between the subspecialist gap and the DEXA gap.
Sure.
So I think to market these tools to be able to not only do this prospective so that we could start to find patients and do, I would say, intelligent primary prevention, which the field has tried to do for 20 years, to be able to plug into the IT system of a hospital, find an X-ray from 2 years ago, be able to measure that bone mineral density and say, hey, Mr. Smith, we did this analysis and we see that you have osteoporosis based on an X-ray from something else that you had a year or two ago. We now need to bring you in to get diagnosed to see if you need to go in treatment. So I feel like this is going to really help exponentially drive this work. And then on top of it, CMS right now is looking at a scheme to really improve the reimbursement for these care coordination models, because there is a lot of gaps in especially the softer care coordination work. And we have 25 years of data on this model that shows that it increases patient outcomes, reduces total cost of care. The challenge that a lot of folks are still in fee-for-service land, that they get paid to fix every one of those fractures, and they don't get that healthcare cost savings if they have one of these programs back in pocket. So I think that's another.
But as they move to an ACO model, it's going to be more important to try to be more proactive as well.
Yeah, and I think too, I've learned in this model that the physicians and nurses that want to set these up, that of course part of that needs to be creating a business case that they bring to their administration. They don't feel like that's an area of expertise for them. And then to have the tools to be able to really show, hey, this is our estimated 2, 3, and 4 year bottom line.
Right.
Because at the end of the day, and I've been on calls with the C-suite and they go, so tell me how this works. We're going to hire an MP or PA that we're going to have to pay $100,000 to $120,000 a year. And we're going to have a dedicated room for a DEXA and some other things. So there's a lot of
my return on my investment there.
And then on the back end, you're telling me that this program is going to lead to 20 or 30 less fractures coming through the door, which of course we don't want more fractures for our patients. But if I look at it purely financially, how does the math work if CMEs and the payers are getting the cost savings back in their pocket and we're not, we're just getting the cost.
Exactly. And unless you're truly a capitated structured model, it's, to your point, there's not a lot of real value to make that huge investment as well. And given the fact that we as patients now have to obviously advocate for ourselves and think about ways of preventing this, or at least understanding where we are in the journey, what are some early stage signs or symptoms or warnings that someone can monitor themselves or loved ones, or just give them some sort of indicator that, hey, maybe I do need to get further testing to see am I in the early stages of osteoporosis?
Yeah. The main one, of course, would be a fracture from a fall from standing height. Because as I said, there are many patients that have an ankle fracture or wrist fracture in, say, their 50s that should have been assigned to osteoporosis. I guess it's a call to action to the folks on the podcast today. If they've had a fracture, to even if it happened 5 years ago, go back to PCP and say, hey, I had a fracture in the past. Let's suggest that I go have a DEXA test, baseline bone density is. And then obviously as we talk about this kind of three-legged stool. So if you have osteoporosis, it's therapy. Of course, if you have osteoporosis, but then it's also exercise, making sure you're doing weight-bearing exercise, and certainly making sure that you're getting adequate supplies of vitamin D and calcium. The preference is definitely that you get that through food rather than supplements, but especially vitamin D is very difficult to get through foods. That's something that most people supplement around. Obviously, if you're focused on it is a little bit easier on your dietary habits and whether you eat dairy, but obviously dairy is the best sources. So I would say from a prevention perspective, there's that piece. And then also, if you have some of those major risk factors like glucocorticoids, smoking, also if you have it in your family, because one of the other big risk factors is it's genetic.
Right.
If a parent or grandparent has had a hip fracture or multiple fractures, that's another reason. There's a couple of good risk calculators out there. So there's one called FRAX, F-R-A-X. You can find online that you can plug in your risk factors. If you have a DEXA score in terms of that specific numerical score, you can put that in. And then what it spits out is the estimate of you having either a major osteoporotic fracture or specifically a hip fracture in the next 10 years. So that's a helpful tool. And then some of the folks that I've worked with as well have great patient-facing education. So I'm working at the National Spine Health Foundation as an example to build the understanding of the connection between spine and bone health. So of the 2.5 million fractures right now, about 1.5 million of them are actually in the spine. And this is where we even have misdiagnosed fractures that actually occur. Because obviously, if you break your wrist or your hip, we know it's broken. But there are a lot of people walking around thinking they have a low back pain where they actually have a fracture and they need intervention. One of the big things that's happening in the spine health field and the surgical field is to make sure that before a patient has any kind of spinal surgery, spinal fusion, maybe surgery to fix that vertebral fracture, that they measure that bone density, because obviously if they've got poor bone health and they're about to undergo this surgery that may be screwing pedicles and things into their spine, it's not going to take, because as I've talked to orthopedics, they said an osteoporotic bone is like butter and nothing adheres to it. So then back to the reimbursement piece, because a lot of these programs are part of various kinds of bundle payment programs. If there was to be a readmission or revision surgery needed, that institution is going to be on the hook for that additional hospitalization. So just from a financial perspective, they're also very motivated to find those patients that have osteoporosis. And then, as I said, with the AI machine learning opportunities, they also have the ability to do that at scale so that there isn't that, we have to wait 6 months for a DEXA before we can do this. And then obviously, if these patients have osteoporosis, it's not an easy discussion to talk to the patient about, hey, I know we wanted to have this surgery next week, but now we've got your bone density score back. And actually, we're going to recommend delay 3 to 6 months so we can get you on an osteoporosis therapy to build your bone so that you'll have the chance to have a much more successful surgery, which is hard to hear, especially if it's something where you're in
a lot of pain.
You're going to have to get some help to get through that pain, but be able to articulate the reasons for it, and that it's going to lead to a much better outcome in terms of surgically as well as for you to get back on your feet. So, that's just an example of some of the things that the bone health field is doing to try to tackle this in a different way.
You've definitely given me a lot to think about as well, too. One, looking at the genetics, for example, I have an aunt who she's in her 90s now, but she has a severe case of osteoporosis, so that's obviously a part of my genetics as well, too. And then two, my doctor has said I need to be taking more vitamin D supplements as well, too. And I haven't been, I'll just be honest. So that's something I need to be thinking about as well, too. And then I was recently in a car accident and I actually herniated 5 discs in my back.
Oh, geez.
So I've been going through some physical therapy and obviously had x-rays and all that done. And they've seen some deterioration in my spine as well, too. They think it's arthritis, but maybe it's something else. I don't know. So to your point, I need to probably have additional tests done to see where I'm at in that spectrum of my bone density, whether or not I'm predisposed to maybe being one of those men that 1 in 5 or 1 in 4 men who may have this illness.
Yep. And there's another test. It's called there's a company called MediMaps that has a test that is a software attachment to a DEXA that the DEXA measures bone density, but then this test actually measures bone quality. So just the data shows us that sometimes there are people with poor bone quality that maybe have either a normal bone mass or a low bone mass and not full bone osteoporosis, that because of their bone quality, they're much more likely to fracture. So that's also something that many specialists are using to be able to more minutely diagnose someone that might have okay bone density, but that the bone quality is not good. Because like when you look at x-rays of what an osteoporotic bone looks like compared to a normal bone, it almost is like Swiss cheese. So there's many more holes in it. So you can understand exactly why a bone that has a lot of holes in it is going to be more likely to break than something that is much more compact. So I think that just shows that piece. And then even some of the startups in the machine learning AI space are tackling that part of the equation as well.
Exactly. Prevention and management of osteoporosis is obviously involved. It's a multifaceted approach. You talked about a number of different things. And obviously early intervention and lifestyle modifications can help you maybe slow down the progression of this disease, or maybe even, I won't even venture to guess and say it will prevent it, but at least definitely slow down the progression. What are some things people should be doing? You talked a little bit earlier, or you mentioned a little bit earlier about exercise and things of that nature, but talk a little bit more, peel back the onion a little bit more on things people can actually do to be more proactive in early intervention and lifestyle modifications to hopefully reduce their risk associated with this disease.
Yeah. So first, it definitely is, if you're not doing it, some kind of weight-bearing exercise. So depending on, of course, arthritis and other things, you might not be able to run. You might not be able to weight train. I weight train, and I think it's not in the youth as far as I'm concerned. But obviously, if you're osteoporotic, you're not going to be able to squat 400 and deadlift 600.
Right.
But there are things you can do with machines, and even from a cardio perspective, biking is going to be better than nothing, but not super weight bearing. But if you walk on an incline or Stairmaster, whatever that might be, and certainly as part of the PT and physical therapy that some folks get, they certainly get prescribed that and understand how to do that. And there certainly are there's some great tools out there. There's actually a company called Wellin that has it's an online exercise platform specifically made for osteoporotic patients. Depending on your level of risk, they'll give you a different kind of exercise program based on what you should be doing, because in severe osteoporosis, literally people can break a bone sneezing, hugging their grandkids.
Oh my God.
People are very fragile. And I guess the other thing just to say in terms of osteoporosis is that my opinion and an opinion of a lot of key opinion leaders is that it's actually the spectrum of a bigger disease. So the idea that if you are frail, you have sarcopenia, you're more likely to fall. And of course, if you have osteoporosis and you fall, you're likely to fracture.
Sure.
There's also a lot of work happening on the muscle side, because obviously if you're frail and you don't have that muscle mass, and obviously as you get older, if you don't weight train or do anything, you're going to lose that muscle mass. It can really lead to more likeliness to fall, and then knowing that there's a big disconnect between the two. So that's the other thing to look at is protein intake in addition to vitamin D and calcium, because that's going to help maintain and grow your muscle mass. And then certainly if you're able to do some kind of weight-bearing exercise, weight training, I think is optimal. If you can do it and keep it up, is where you want to go.
You had mentioned earlier some of the advancements that are taking place in this industry in terms of diagnosing this disease, things like AI and machine learning. But are there other advances in research that are noteworthy and worth sharing with our listeners?
Yeah, thanks. So I would say the big one that's on the horizon that I think is going to happen in a pretty short period is some work that the Foundation for NIH has done around looking at all of the clinical trials that have happened to date and engaging with FDA on their biomarker qualification process to change the kind of endpoints of future osteoporosis drug trials to be bone mineral density improvement and not fracture reduction. As you can imagine, if one of your endpoints is fracture reduction, you've got to have a huge cohort of patients that you're going to follow for a very long period of time, where the goal is now to have bone mineral density as that primary endpoint, which will obviously lead to needing much less patients in these trials and for them to be able to do it much more rapidly. I think as I was leaving Amgen in 2021, I was thinking that the product Evenity that I worked on while I was there, which is one of the newest drugs, might be the last one in osteoporosis. And I think this really opens the door to more companies to develop osteoporosis therapies that still are needed, even though we have quite a few available. To me, that's really exciting on the research side. And then certainly there's even more work being done in terms of supplements and other things, because there is, of course, a subset of people that no matter what you tell them, they're never going to go on a drug. So there also are companies that are bringing like vibration platforms that help build bone density.
Oh, interesting.
There is a diverse kind of swath of stuff that is available. But I guess I would say to the folks that might be listening, there are times where you are going to have to go on a therapy to address this. No, I think that's the other thing, is to be open to that and to understand that the therapies have improved quite a lot from those first therapies in the 90s. And I think there still is an impression that some of those rare and adverse events are happening with all of the therapies, and it definitely has improved. I guess that'd be the other thing to say is read up on some of the newer therapies that are available, and there are a lot. The newer biologics are the ones that are the bone builders that are going to get these patients out of that danger zone.
Sure.
The quickest, be open to that and make sure that your physician as well is aware of all of them, because it's not easy. And then maybe it is need to get a referral to a specialist if, say, your PCP doesn't feel confident in making a diagnosis and figuring out what specific therapy would be best for you.
Exactly. I have two final questions for you. The first one is, can osteoporosis be reversed through treatment? And then the second is, any final thoughts or advice you would give our listeners as if they have been diagnosed with this disease or trying to figure out where they are in their journey as they get older, that you would share with them?
Sure. So I guess first, in terms of whether osteoporosis, it certainly is preventable. I would say it is like many chronic conditions. You maybe have to be on therapy for your life or a good part of your life. But the nice thing about these therapies is that they continue to work in the long term. So I would say it isn't a curable disease in that you take a pill and then it goes away. And certainly, as we talked about, you've got to do the diet and exercise part of that as well. And even you actually need to have adequate supplies of calcium and vitamin D as well for these drugs to be the most effective.
Sure.
So I would say it is a preventable disease. But I think with almost any chronic disease, the earlier that you start to intervene, the better. If you have less severe osteoporosis, you may not need to be on the very most anabolic therapy. And of course, what's happening now is we're catching patients when they've already had osteoporosis for 20 years and maybe didn't realize it. And then I guess the other thing to say is that these aren't a guarantee that if you go on a therapy that you're never going to have a fracture. It certainly greatly reduces your risk. So there could be times where you're on a
recovery, I would imagine too, right?
Yeah, and recovery. So I think unfortunately, there's no guarantee in any therapeutic space that you're 100% cured. But to get that general 50% reduction in fracture risk is a huge opportunity. And obviously, at the end of the day, we want to avoid that hip fracture because that's the one that's going to kill 1 in 4. It's going to be really devastating to the person. And even learned in a lot of the conversations with patients that like thinking that they were going to have to move from independent living to a nursing home in many patients is a fate worse than death.
Sure. Absolutely. Absolutely. Wow. I tell you, I've learned quite a bit today that I'm going to take back for myself personally and for my family and loved ones as well. I'm definitely going to look at trying to get a bone density test. That's for sure. As well as I'm going to listen to my doctor and start taking my vitamin D. I've got some in the cabinet. I need to start taking it on a regular basis. But more importantly, I also think that the thing that's really enlightening for me as a male is that this is the disease that affects us as well, too, and that we have to be sensitive to that, as well as our wives and loved ones also, as they start to go through their life changes and journeys as well, too, and how this can be impactful as well, too. Again, David, thank you so much for providing your perspective and expertise on this subject that's not really talked about a lot until something happens. And I'm so excited that we were able to share this with our listeners. And I hope that they would take your advice as well, too, and go and get tested and figure out where they are in the journey and their loved ones and know that there are all these different alternatives out there for treatment and for prevention as well, too. With that, I'm going to close the show and thank my listeners, as always, for taking time out of their busy schedules to listen in. If you really enjoyed this and you found this to be a very informative discussion, please share this with your friends, families, loved ones, people you don't like, anyone you think that could benefit from the insights that David shared today. Thank you so much for being ongoing supporters of Straight Out Health IT. Until next time, take care and God bless.
Thanks so much. Thank you.
Thank you so much for listening to Straight Outta Health IT. We hope you enjoyed today's guest. For more unfiltered dialogue of healthcare leaders and influencers, be sure to tune in next week. For the show notes, transcripts, and resources, please visit Apple Podcasts, Spotify, or your favorite streaming platform. We invite you to give us feedback by reaching out to Christopher Cuddy on LinkedIn, just searching for Straight Outta Health IT, and you'll find us. We are constantly having live discussions about diverse topics in the industry.